talk about cohort study design, and the main objective for this session is talking about incidence and prevalence, calculating them, interpreting them. Then after that, looking at cohort study design, looking at the types of cohort study design, what is attributable risk, relative risk, population attributable risk, how that can be calculated, and finally interpreting it. Then finally, we'll end the session with the advantages and disadvantages of a cohort study. So first, talking about prevalence. What is prevalence? It is a measure of total number of people that is affected by a disease at a particular point of time. And what it primarily tells us is the current burden of a disease in a population. And the way one can measure it would be the number of cases upon the total population into 100. Now, whenever we use the term prevalence, it means that we're talking about point prevalence. Now that we've come to the part of point prevalence, there are two types of prevalences that exist. One is a point prevalence and one is period prevalence. Both of it is very, very evident from its name, what it suggests. So the point prevalence is nothing but the number of people with a specific disease at a point in time divided by the total population. When we talk about period prevalence, we talk about the number of people with a disease in a particular time interval divided by the number of the total population. And this prevalence can be, this period can be anything. It can be a month, a year, or a decade. And period prevalence can, there's another way to understand this particular thing. That is, it is a prevalence at the beginning of an interval plus any incident diseases. Now, in order to just nail this concept, let's practice an example. So in this particular example, a population of 150 people for 1 year was taken. 25 people already had the disease at the start, and another 15 new cases developed over that year. Okay, so the first thing that we will be discussing would be the period prevalence and the point prevalence for this. So what do you all think is the point and the period prevalence for this? Let's talk about the point prevalence first. You all can put it in the chat box or just unmute yourself and let me know what do you think is the point prevalence for this example. Totally, there are 150 people in the population. Great. I see answers coming in. You're right. It's 25 on 150. That is the number of cases that existed at the point upon the total population. Now let's talk about period prevalence. What do you think is the period prevalence? You all can just put it in form of ratios. Oh, Dr. Deepika, thank you so much. You're pretty fast. So it's 15 plus 25 on 150 into 100. Perfect. Yes. Yes, Gomti. Correct. So as you all can clearly understand, that point talks about the number of cases at that particular point where the study is being conducted, and period is over a period of time. Now that we've understood prevalence, let's talk about incidence. So what is incidence? Incidence is the new number of cases of a disease that occur in a population. And it is nothing but the new cases that arise in a population upon the total population that is at the risk of disease. And at a point when we are considering a population, we consider all of those people at a risk of that particular disease. And in 2000, so one thing that has to be taken in and just remembered is that incidence is usually calculated per 1,000 population and not per 100 as we did it for prevalence. Now let's understand incidence with another example. So in a particular village of a population of 5,000 women, there were 50 that were diagnosed with uterine fibroids at the start of 2019. And by the end, that number was 100. So now we have to calculate the following, the point prevalence. So what do you all think is the point prevalence in this particular case? Just refreshing the numbers, 50 at the start, at the end there were 100, and the total population under study is 5,000. Feel free to unmute yourself or just put it in the chat box. Yes, I see quite a few answers now. You're correct. It is 50 on 5,000 into 100, which is 1% when calculated. Because 50 is the number of cases at the start, and then we had 5,000, that was the total population. Great. Now let's talk about the annual period prevalence. Again, to just revise those numbers, we had 50 at the start. Then by the end of the year, we had around 100 patients of fibroids, and the total population was 5,000, I'm sorry. So what would be the period prevalence in this case? It's so nice to see you guys have actually calculated the values. I mean, even if you'll put on fractions in the chat box, that would be really good. Wonderful. Great. Great to see the answers. So the total number of cases at the end were 100. So since there were already 50 at the start, and we mentioned that there are 100 at the end, so that already includes the 50 that we started with. So we talk about the total number of cases at the end of 2019, that would be 100 upon 5,000. That is the total population into 100. I see that some of you guys have put 150 upon 5,000. Have I been able to clear your doubt now why it would be 100 and not 150? Because when we started with 50 and we ended with 100, those 50 were already included in that 100, if that makes sense. Great. Now let's talk about the incidence of fibroids in this case. What do you all think is the incidence? Okay. Any other answers? Feel free to unmute yourself or just put it in the chat box. What do you all think is the incidence of fibroids? So again, just to recall the case scenario that we're discussing, we had 50 cases at the beginning. At the end of 2019, we had 100 cases of fibroids, and then we had a total population of 5,000. Great, I see the right answer. Yes. So since the new cases, it would be, when we talk about incidence of fibroids, we talk about new cases, about the total population. When we started with 50 and ended with 100, we know that 50 new cases were formed. And that's the reason it would be 50 on 5,000 into 1,000. And here we, and 1,000 is important here because we're talking about the incidence of fibroids. And the reason why we take 5,000 or the entire population in the denominator, because we assume that the entire population is at risk. Now let's just dive into the interpretation of each of these three things. So first we spoke about point prevalence. So we found that the point prevalence was 1%. So what did that signify? That signified that 1 out of every 100 people was a fibroid patient at the start of 2019. Then we spoke about the period prevalence, where we calculated it to be 2% for this particular example. So the way that could be interpreted is that 2 out of every 100 people were fibroid patients in the entire year of 2019. And then finally, we spoke about incidence. So that could be interpreted in a way that, since that was found to be 10, so that could be interpreted in a way that 10 new cases of fibroids per 1,000 population were found in the year 2019. Now we have a few polls based on incidence versus prevalence. All you have to do is, there is like a question asked, and you all have to just mark whether do you think it's incidence or prevalence. Shri, can you please upload the first 3 polls? Thank you. If you all are wondering how to see these polls, feel free to go into the activities session on the right-hand side and then go to the poll section. There you all will be able to see all the 3 questions. I'll give you all a couple of minutes, about 2-3 minutes. Feel free to just choose an answer of what you all think.
Hi Zainab, this is Ovia.
Yeah,
I have a
hi.
quick question while everybody votes. In the previous question, the denominator is the population at risk, right?
Yes.
So why didn't we take off the 50 people who already had the disease?
Because even though they're the ones who, because we're talking about those who are at risk, so whether developing a disease or not is kind of like a probability, like it's just a chance whether one forms the disease or not, but all of the entire population is at a risk of getting the disease. Does this
So
answer
whenever we are calculating incidence, people who already are counted in the prevalence of the disease still get included in the population under risk. Is that right?
Yes.
Okay. All right. Thank you.
Great question. Okay, let's discuss the poll answers. So for the first question, I see a lot of you guys have almost given equal percentage to incidence and prevalence, although a little more on the incidence side. So you all are correct that incidence requires follow-up. So every time we need to follow up in order to look at new cases that are developing. That's the reason incidence requires follow-up while prevalence does not. Now let's discuss the second question. What depends on the duration of the illness? Incidence or prevalence? Um, the uh, prevalence depends on the duration of the period. So duration of the disease, I'm sorry. So if there is a long duration of a particular disease, that will eventually lead to the increase of prevalence of a disease. While incidence does not depend on anything, whether a disease is of a longer duration or a shorter duration, it's not going to be affected. Finally, what is the preference when measuring the burden of a chronic disease? Um, Again, you all are right. So you all are right on all 3 polls. Even on this question, prevalence, yes. So whenever we're talking about a chronic disease or estimating the population burden, then we look at prevalence. And incidences are more preferred when we're looking at the relation between cause and effect. And as just recapping a few points, probability of developing a disease is the incidence, while probability of already having a disease is prevalence. When incidences, we talk about new cases. With prevalence, we talk about both new and old cases. And in totality, we talk about all the diseases that exist. And then prevalence does not require follow-up, while incidence does. Prevalence depends on the duration of disease, while incidence does not. And prevalence is really, really good in order to estimate the population-based burden of a chronic disease, while incidence is good to understand the relation between a cause and effect. Okay, now in order to just nail down how incidence and prevalence vary with different situations, let's take this example. So a patient has endometrial carcinoma. Hypothetically, the condition has no treatment and only symptomatic management is followed, ultimately the patient dies. Now we have certain scenarios coming ahead where you all have to just put it in the chat box or even unmute yourself and let me know what do you all think. Would incidence increase, decrease, or stay the same? Or prevalence increase, decrease, or stay the same? So the situation one over here is a clinical trial, a successful clinical trial introduces a new drug that slows down the disease process. It does not cure the disease, but slows down the disease process. What do you think is the effect on incidence and prevalence? You can put it in the chat box, unmute yourself. What do you think? How does incidence and prevalence change? Okay, I see answers. Great, you all are right on the incidence part, but prevalence, let's discuss that. So as you have mentioned, incidence remains same and remains unaffected because again, the drug has no role in prevention of the disease or the occurrence of the new case. While prevalence will increase, and let's understand why. This drug is slowing down the disease process, right? So what happens because of this is those people who would die earlier now live longer. And therefore, at a particular period of time, there are more number of people living with the disease. Therefore, prevalence increases. Great. Now let's talk about the second situation. A case control study established that the disease was caused by smoking. And therefore, a lot of public health awareness programs and population were made aware about this, and some of them quit smoking. So how does this affect the incidence and prevalence of endometrial carcinoma, in your opinion? Both decrease, okay. Okay, I see a few answers, both decrease. Okay. So you're right, both will decrease. So what happens due to an awareness session is that we know that we were able to reduce the risk factor, where we were able to motivate people to reduce or quit smoking. And therefore now there are lesser number of people who are going to form that disease, and therefore incidence will decrease. At the same time, when incidence is decreasing, now lesser number of people actually have the disease. So over a period of time, the prevalence will also decrease. So you all are right on this. Both of them will decrease. Now let's talk about the last situation, where there was a new trial done by a gynec by performing hysterectomies. What do you think would be the effect on the incidence and prevalence of endometrial carcinoma in this particular case? Okay, I see answers. Wonderful. Y'all have got it all right. So as you all have mentioned, that incidence would remain unaffected because the modality, that is hysterectomies, has no role in the prevention or the formation of the new disease. So therefore, incidence remains unaffected. While this technique will cure the disease and affected people can become disease-free, and therefore that would decrease the prevalence. So incidence remains unaffected while prevalence will decrease in this particular example. Um, Now we've gone through the entire section of incidence and prevalence. We spoke about how to calculate them, how to like compare between the two. We saw a lot of case scenarios. I know this can be a little overwhelming. Are there any questions at this point? Yes,
Good evening, ma'am. I just have a small question.
sure.
Could you please explain the part where you informed us regarding, we don't take that extra 50 during the calculation.
Okay, sure. I will just go back to that slide. Okay. Before I get to that slide, I will just explain the question a little better so that it can be more understandable. So here we know that the entire population is 5,000. There were already 50 diagnosed cases of uterine fibroids at the start of the disease, of the start of 2019, I'm sorry. And then by the end of 2019, we had 100 cases of diagnosed. So I think your doubt is how we are looking at point prevalence, where the not the point prevalence, I'm sorry, annual period prevalence, I guess, where it's 100 and not 150.
Yes.
Yes. Okay. So here, because we already mentioned that at the end of 2019, there were 100 cases. So we don't need to add any other thing, because already it's mentioned that those 50 that started, plus there were another 50 during that period. So by the end of the period, we had 100. So that was already mentioned in the question, that by the end of 2019, it's 100 people. And we're looking at the total number of cases during 2019. That's the reason it will be 100 and not 150.
Thank you.
No problem. Are there any other questions for me? Okay, great. Let's get started with cohort study design. So first, let's understand what cohort means. Cohort means a group of people having common characteristics. And some examples just to understand this is like medical students of a particular batch, or the survivors of COVID-19 pandemic, smokers in a particular age group. So you'll get the idea. It just means that people with a group of people with common characteristics. Now, on the right-hand side, let's look at this epidemiological study pyramid that we always discuss. So every time we discuss, we know that on the base of the pyramid, we have studies that have lesser value, like animal research, in vitro research, editorials, opinions. Then we have case reports and case series. Then among all the observational studies, we have cohort, case control, and cross-sectional. So we know that case control is considered the inferior most among the three. Then we have, case control, cross-sectional is considered inferior most. Then we have case control studies, and finally we have cohort studies. And then above these observational studies, we have other studies like the RCTs, or systematic analysis, systematic reviews, meta-analyses, such studies. So this is like the entire pyramid, and we can see where cohort study design stands. Um, how does cohort study design work? So it goes from the risk factor to the formation of the disease. So therefore, it's forward-looking. We have discussed the differences between a cohort, case control, and a cross-sectional study. So in a cohort, we're looking at forwards. We go from the exposure to the outcome, and therefore it's a forward-looking study. When we talk about case control studies, we start with disease groups and go back in time for exposure. So that is the reason it is backward-looking, or we can say retrospective, in other words. And then finally, we have cross-sectional study, where we look at both exposure and outcome at the same time. Now let's talk about the types of cohort studies. And this is something that we discussed in the second session, but just let's recap this entire concept. So in general, cohort studies are always forward-looking. That is from exposure to outcome. And therefore, you all can always see the arrow going from exposure to outcome. Now, these three types are based on time and not on the study design itself. So when we talk about a prospective type of study, cohort study design, we talk about going from exposure to outcome in the future. So therefore, it's prospective with respect to time. When we talk about retrospective with respect to time, so we go from exposure to outcome, but at the start of the study, we already are at the point where we can get the outcome. So we look back in time, get the exposure, and then follow up and just look at the outcome of those patients. So that's the reason it is retrospective, because we're looking at exposure in back in time. Then finally, we have the mixed cohort study, which is the best of both worlds. That is a mix of both prospective and retrospective. So at the start of the study, we go back in time to look at the exposure. And then finally, follow the patient for a little more period of time and look at the outcome in those groups. And that's why this is called a mixed cohort study. Now let's talk about the framework of a cohort study design. Just like any other study design that we've spoken about, first, it's important to select a study population. Then obtain data on exposure, select groups of comparison, then finally follow up those patients, and finally look at analysis. And as I've already mentioned, in a cohort population, we look at two groups. We start with the exposed group with the risk factor and the unexposed group, and then look at the disease formation in both these respective groups. Now let's talk about the steps of a cohort study design. And as you all know, that any study design we talk about, first we talk about the research question. So let's take a hypothetical research question. Is smoking a risk factor for preterm birth? So then we form the null hypotheses and the alternate hypotheses. In this particular case, the null hypotheses would be smoking is not a risk factor for preterm birth, while the alternate hypothesis would say smoking is a risk factor for preterm birth. We understand that for the null hypotheses, it is always opposite as compared to the intended result. And at the end of the study, we usually reject the null hypotheses and accept the alternate hypotheses. And it could be either way, but this is just the norm that we follow normally. Now let's talk about the steps of a cohort study design. So as we know that the first step would be selection of a study population. Second, we would look at the exposure step or the exposure, determine the exposure. And then third, we would look at comparing between the groups. So the first group is the exposed group. In our case, it would be 100 pregnant women with smoking, while the non-exposed group would have 100 pregnant women without smoking. And as we know, the former group would be test group and the latter would be called the study group. Normally, between the two groups, we would like a ratio of 1:4 between test and controls, but there should be at least a ratio of 1:1 among those patients. Now, some important considerations to keep in mind while performing a cohort study. So a cohort must be free from disease under study. So people who are diagnosed with other complications in pregnancy, for example, here we're talking about preterm birth, but those who are having maybe gestational diabetes mellitus or having any other complication should be excluded from the study. And both study groups should be equally susceptible to form the disease. We should not include patients, for example, with previous history of preterm birth, because that makes them more likely to just develop preterm birth, and that would be like a confounding variable in our study. Confounding variables will be explained in detail in further sessions, but for now, it would be easier to understand that we need to look at our population without any risk factors like advanced maternal age or multi-gravid patients or of those with multiple gestations like twin pregnancy. All these risk factors make a pregnant woman more likely to develop preterm birth, so we don't want those interfering with our results. And then finally, we also look at including people based on the inclusion criteria, and this inclusion and exclusion criteria must be decided beforehand. Now, the fourth step, which is a very important and unique step of cohort study design, where we will be following up patients. So usually in a cohort study, we need a large proportion of people, and we will follow up with them until an extent where a large proportion of participants have reached an outcome. That can be maybe in months or years or decades, but when a large proportion of people have actually formed the disease. And in our case, that would be the end of pregnancy. So as I've mentioned it before, and I always talk about it, we all start with exposed and not exposed, and then we follow them up till disease formation versus non-disease formation. Now in this particular study design, since it's prospective in nature, that is, we're going from exposure to outcome, this is a prospective study, and we're able to calculate the incidence of a particular disease, because your new cases are actually being formed by the end of this study. And therefore, this is also known as an incidence study. So in this particular example, we selected our study and control group in 2020, and we followed these patients until the end of pregnancy to check for preterm births. Now let's just see how we can statistically analyze this situation. So for a cohort study design, we usually calculate the relative risk in order to understand the association between exposure and disease formation. So for this, as we've done it with previous study designs, we form like a table where we put exposed and not exposed groups in the rows, and we have disease formation versus not disease formation, no disease formation in the columns. Now let's hypothetically, to understand the situation, name situations A, B, C, and D. So exposed patients who actually develop the disease, let's call it A. Those who were exposed and did not develop disease were B. Those who were not exposed and developed the disease were C. And those who were not exposed and did not develop the disease were D. So in this particular case, when we talk about relative risk, we talk about incidence of a disease in the exposed divided by the incidence of a disease in the not exposed. In this particular example that we're talking about, it would be A upon A plus B. That would be the incidence of disease A in the exposed upon A plus B. And then when we talk about not exposed, those who developed disease were C, while the total population of not exposed was C plus D. So it would be C upon C plus D. And when we take a ratio of the two, it would be A upon A plus D divided by C upon C plus D. But instead of actually learning this formula, it would be much more beneficial in order to understand how we are coming up with this. It is the incidence in the exposed divided by the incidence in the not exposed population. Now, in our case, let's just put in the values. Hypothetically, we have taken two groups of 100 each. That is, exposed were 100, that is smoking. Not exposed, non-smokers were 100. Those who developed preterm births were 20. In the exposed group, those who did not develop were 80. In the non-smokers group, those who developed preterm births were 5, while who did not develop preterm births were 95. So looking at this table, would you all like to tell me what is the incidence of preterm birth in exposed population? You all can put it in the chat box, so just unmute yourself, and you all can put it in terms of fractions. Okay. Yes. Yes. I see a lot of answers, and you all are correct. Perfect. What about incidence in the not exposed? Yes. Wonderful. You all are getting it right. So yes, it would be 20 upon 20 plus 80. And then you all can multiply it into 100 or not. Like I see a lot of you all have, because or 100 or 1000 in this case, because we know that incidence, whenever we talk about incidence, we multiply it by 1000. But whether we do it or not, it doesn't matter, because here we're going to take a ratio. So let's just look at the basic numbers instead of like talking about the multiplier, because that's going to get cancelled out either ways. So it would be 20 upon 20 plus 80, that is 100. And then we have 5 upon 5 plus 95, that is 100. So the incidence in the exposed group is 20 on 100, and not exposed is 5 upon 100. And we can clearly see that the incidence of preterm births among smoker is
Sorry for the interruptions, everyone. Zainab will be joining us in a minute.
Hi, Shri. Am I audible now?
Yeah, you're audible.
Yeah, thank you very much. I'm so sorry for this technical glitch. Actually, the thing is that I had like a electricity cut in my place. I will just try to present this screen. Just give me a minute. I hope my screen is visible.
Yes, it is.
Perfect. Okay. So I was talking about, as we can see with this example, that the incidence has been higher with the cases as compared to the controls, that is the other not exposed group. Therefore, but still, just with the incidence, we're not able to actually establish a causal association. That's where relative risk comes into picture. So where we're taking a ratio of the risk in the exposed upon the risk in the not exposed. And in this particular example, as you all mentioned, it was 20 on 200 upon 5 on 100. That would come up to the ratio of 4. And how we could interpret this particular result is that smokers have a 4 times more risk of developing preterm birth or giving rise to preterm birth in comparison to non-smokers. Now, I think let's practice this example in order to understand interpretation. A cohort study design was done to establish a causal association between smoking and gestational diabetes. A relative risk was found to be 0.3. What do you all think does this signify? You all can put it in the chat box or just unmute yourself and let me know. What do you all think does this signify? 0.3 between smoking and gestational diabetes. Protective, okay. More risk, okay. I'll just give you all a couple more minutes. Okay, great. So as someone mentioned, Manswani mentioned that there is a protective This is what it shows, that smoking is protective for gestational diabetes, and those who are smokers only have like 0.3 times chance of developing the disease. Now let's talk about interpretation of relative risk in general. So a relative risk of 1 would show that the exposed and unexposed groups are equally likely to develop the disease, and therefore there is no association between the two. When we talk about relative risk less than 1, that shows that the exposed group is less likely to get the disease than the unexposed group, and therefore it is protective. And then a relative risk of more than 1 would tell us that an exposed group is more likely to get a disease, and therefore there is a positive association between the two. Now let's talk about what attributable risk is. So relative risk gave us a good idea of the relationship between the cause and the effect. But what attributable risk tells us is the proportion of the disease that is attributed to a particular risk factor. And the way one can actually calculate this is the incidence of the exposed. So here in this particular graph, you all can see the incidence of exposed, subtracting the incidence of not exposed. So this is removed. So all you all can see that this is the proportion that is exposed minus unexposed, divided by the entire incidence of the exposed population. And that would give us the attributable risk. That is the percentage of the disease that is attributed to a particular risk factor. In our particular scenario, it would be a 0.2 minus 0.05 that we found upon 0.2. That would be about 0.75. And in percentage, that is 75%. So hypothetically, in our case, we found that 75% of all cases of preterm births can be attributed to smoking. And this is a very good measure of letting us know how much a particular part of a particular disease can be attributed to a particular risk factor. Now let's talk about the next parameter, population attributable risk. But before we get to that, let's talk about how to calculate the total incidence. So you all know the concept of incidence. We have this particular hypothetical situation where we have 100 smokers versus 100 non-smokers. 20 among the smokers developed preterm births while 80 didn't, and similarly 5 people developed preterm births among the not exposed population, with 95 at no preterm births. So what do you all think would be the total incidence of a particular of the particular disease? That is preterm births in this particular case. Okay. Any other answers? Wonderful, you'll have all got it correct. So the total population attributable risk, the total incidence, I'm sorry, would be 25. So it would be both the entire diseased population, that would be 20 plus 5, that's 25, upon the total number of people in both the groups, 200 into 1,000. So 50 is correct. Now let's talk about how we can calculate population attributable risk. So population attributable risk would be the total incidence that we found in the entire population, subtracting the unexposed, as it can be seen in this particular graph. So it would be this particular portion divided by the total incidence. And what this parameter tells us is the contribution of a risk factor to a disease. And this takes in mind, or takes in picture of the entire population. And so in this particular case scenario, as you all had divided it, it would be about 0.125 if we just did not put in those 1,000 values and just kept it as a fraction. So it would be 0.125 minus 0.05 upon 0.125. So that would be about 0.6, that is 60%. Would someone like to try or just like put it in the chat box or just unmute yourself and tell me what does this 60% signify? How would we interpret this? Keeping in mind that population attributable risk tells us the contribution of a particular risk factor to the disease in the entire population.
%60 population will be protected if people stop smoking.
Okay. Not exactly, but you're close. Thank you for answering. Okay, so this can be a little tricky. So what this signifies is that 60% of preterm births can actually be eliminated or reduced if we're able to remove the risk factor. So because it's telling us how much this particular risk factor is contributing, it tells us that how much of the disease can be eliminated from the population if that particular risk factor is eliminated. So this would be the interpretation. And then, as we already know, that cohort study design always establishes a temporal association because we're going from cause to effect. And another very quick note here is that population attributable risk can also be calculated as the difference of the incidence in exposed minus incidence of not exposed. And this would be a risk difference. Although the way we were doing it in terms of proportions, that's much better. But this is also another way it can be calculated, that is the risk difference. Now we have a few polls based on the concept that we learned on relative risk and attributable risk. Shri, please, can you upload the last few polls? Thank you. So what do you all think? What would be better for assessing the etiological role? A relative risk or attributable risk? Similarly, what do you think gives a better idea of the impact of successful preventive or public health program? It would be attributable risk or relative risk. I'll give you all a couple seconds to just answer this. It's wonderful to see such active participation. Okay, great. Let's discuss the answers. So for assessing the etiological role, relative risks are much better because I mentioned that it gives a very good association between exposure and outcome, and therefore relative risk is much better than attributable risk when it comes to the parameter of getting an association between exposure and outcome. Now the next question. What gives a better idea on the impact of a successful preventative or health program? Public health program. You all correctly mentioned it is an attributable risk because we understand that what attributable risk does is tells us the percentage of the disease that can be attributed to a particular risk factor. And therefore, since we're able to get how much is attributed by what, and therefore we can understand whether a preventative or public health program has a significant effect in reducing a particular problem. So great job, guys. You'll have got it all right. Now we're coming to the last section of our session, where we'll be talking about advantages of cohort study design. So one of the biggest advantage here is we can actually calculate incidence. Reason being, we're looking at formation of disease over a period of time. We're following up patients over a period of time to see formation of disease, and therefore incidence can be calculated. And we can look at several outcomes at the same time. We could probably look at maybe the development of some other disease as well. So that's another advantage. It helps us understand, it gives us a direct estimate of relative risk and tells us the association between exposure and outcome. And those response ratios can also be calculated through this. And the bias, there are a lot of biases that we'll be talking about in future session, but many of the biases can be minimized with this particular cohort study design. Now, talking about the disadvantages, one of the biggest disadvantage of a cohort study design that involves a lot of people, and it's unsuitable for study of a disease with low incidence. Now, at this point, I would like to ask, because we've already discussed this in our previous sessions, what do you all think is a good study design to look at rare diseases? In order to study rare diseases or those with low incidence, what type of study design is better? Oh, wonderful. I'm so happy to see y'all responding case control. Y'all are absolutely correct. Another disadvantage of cohort study design is that it takes a lot of time to conduct the study because we're following up patients. At the same time, since we're following up, we need to keep an extensive record keeping of these patients, and loss to follow up is very easy in this particular case. Sometimes selection of the comparison group also becomes very, very difficult because we need to keep in mind confounding factors. It can be a little more expensive. Patients may alter their behavior because they're being studied for a period of time. And that is called the Hawthorne error. And that is, again, something that will be spoken about in future sessions. And finally, there are a lot of ethical problems when it comes to cohort study design. So these are some of the major disadvantages. Now we've come at the end of our session, but before we close, I would like someone to just unmute themselves and unmute yourselves and tell me what is the one thing that you learned from the session, or one takeaway that you would like to share with others from the session. You can even put it on the chat box. What is the one takeaway or one thing that you all learned? Okay, so I will just summarize this session for you, so it'll be easier for y'all to recall what y'all have learned. Interpretation of cohort. Okay, sure. The graphs for AR and RR, sure. I can do that. So that's a very good takeaway, Dr. Deepika. The interpretation of cohort. Just talking about a bit of summary, and then we'll come to your question. So we spoke about prevalence, we spoke about incidence, how to calculate both of them, how those two change in different situations. Then we spoke about the types of cohort study design. Then we spoke about relative risk, attributable risk, population attributable risk. And then finally, we spoke about the advantages and disadvantages of cohort. I will just pull up those particular graphs so that we can just go through them again. So what is attributable risk? It is, and this graph is not like a graph that usually exists, but it's just for better understanding, so that we don't need to learn this particular formula by heart, but we're just able to understand it more visually. So in this particular case, for example, if we have a graph of incidence of a particular disease in exposed and non-exposed. Hypothetically, if the exposed bar is this, while the unexposed bar is this. So attributable risk would be the entire incidence of the exposed minus the unexposed. So this part primarily, because this is getting subtracted from the exposed. So this upon the total exposed, and that would be the attributable risk, that the percentage of a particular disease that can be attributed to a particular risk factor. Is attributable risk a little more clearer now, Dr. Deepika? Perfect. Let's talk about population attributable risk. So in this particular graph, we again have an incidence graph where this is the incidence of the entire population of a particular disease in the entire population, while the incidence in the not exposed population. So how population attributable risk looks like is this particular section where from the population unexposed incidence is subtracted, this upon the total incidence in the entire population. So this is population attributable risk. Is this graph a little more digestible or just a little more understandable? Yes, perfect. Great. So are there any other questions for me? Anything else I can break down or just explain a little further? Now that we've come towards the end of the session, we definitely take your questions. But in the meantime, I would request Shri to put the post-event questionnaire in the chat box. Just a quick reminder that the post getting at least 70% on the post-event questionnaire and filling it along with attending the live session is an important criteria to receive certificates. So please make sure that you do fill the post-event questionnaire. In the meantime, we're open to any other questions. Please feel free to unmute yourself or just put it in the chat box. We're happy to respond to questions. At the same time, I know sometimes after the session, we get some certain questions in our mind. So please feel free to email us at research.simsobgyn@gmail.com. At this point, I would also request everyone to just switch on their cameras so that we can take a photograph. Unfortunately, I will not be able to because I have like an electricity cut at my place, but I would request all of y'all to just switch on your cameras. Thank you so much, Dr. Deepika. Thank you, Uvia. Thank you, Astha. It's so nice to see you all. And thank you so much for attending the session. It seems that you all have no further questions, but feel free to email us or just reach out on the WhatsApp group. It was really nice spending this 1 hour with you guys. Shri, would you like to add something?
Hope you all enjoyed today's session and please feel free to ask any doubts.
Perfect. Thank you very much. So you all have a good night and a good weekend. Take care. Bye.